Hi everyone, and welcome to our presentation on the alternative models to address quality of care in individuals with ASD. My name is Katelyn. I'm in my third semester in the ABA Master's Program at Ball State University. I live in St. Louis, and I have 3 years of experience implementing ABA.
Hi everyone, my name is Madison, and I am also in my third semester at Ball State University, obtaining my master's in applied behavior analysis. And currently I am an RBT in Tulsa, Oklahoma, and I work at an ABA clinic that specializes in therapy for children with autism.
Hi, my name is Jocelyn. I live in Apple Valley, California. I've been dealing with working with ABA, working with consumers with developmental disabilities at California Side Care. I am in the first semester at Ball State working on my ABA certification program.
Hey everyone, my name is Ellen, and I'm in my third semester at Ball State. I have 3 years of experience working with kids with autism. Right now I work at a therapeutic day school in Chicago, and I am a middle school assistant teacher.
Hi, my name is Brittany, and I'm from Ontario, Canada. I'm currently in course 7 of 10 to obtain my master's in ABA. I work as a behavior consultant and have held that position for the past 8 years, working with children and adults.
The 3 models we will be discussing are applied behavior analysis, the medical model, and sensory integration therapy. Applied behavior analysis, or ABA, is based around B.F. Skinner's operant conditioning. This includes the idea that an antecedent precedes a behavior, and then the behavior is followed by a consequence. Dr. Montrose Wolff then used these ideas in the 1960s when he began to realize the functions of behaviors he was seeing in the children that he worked with. Beowulf and Risley in 1968 wrote an article discussing dimensions of ABA. These include applied, behavioral, analytic, technological, conceptually systematic, effective, and generality. The article discusses how each of these are important and demonstrate what ABA should be. ABA is used in autism treatment centers, hospitals, group care facilities, factories and offices, schools, zoos, and pet training centers. The medical model was founded by Leo Kanner and Hans Asperger in 1994. The goal of this model is to find the cure and treat autism. Medical professionals like researchers, doctors, and pediatricians use this model. Other models use what is found by this model, but are not as concerned with curing autism, but more to increase the quality of life in those with autism. Sensory integration therapy was based off of Jean Eyre's sensory integration theory when she coined the term sensory integration in 1972. The definition for her term is the neurological process that organizes sensation from one's own body and from the environment and makes it possible to use the body effectively within the environment. The rest of the presentation will discuss each model in further detail, research in all of the models, pros and cons of each, discuss ethical considerations, and important questions. When looking at models for treatment of ASD, it's important to consider when each model would be used. An example of this is when would SIT be used. According to the American Occupational Therapy Association, SIT is used when after evaluating the child's occupational performance deficits, the therapist concludes that one of the underlying causes for these performance deficits is a result of poor sensory processing. Next, Brittany will discuss each model and what they are about in further detail.
The first model we looked at was applied behavior analysis. This theory focuses on teaching new skills to replace maladaptive behavior. The behaviors are defined and are both observable and measurable. ABA programs are individualized and tailored specifically to the client. ABA applies principles of behavior to change or improve behavior and evaluates to ensure that the behavior changed was a result of the intervention. The behaviors to be changed are of good or are of social significance. Results of the intervention must be generalizable, meaning a behavior that is learned and applied in one setting can be applied elsewhere, school, home, and community, for example. Next, we looked at the medical model. This theory focuses on using medication to decrease or improve behaviors associated with ASD and other behavior disorders. Children have been shown to benefit from one or more of these medications. Different medications are used for different concerns. Some medications used frequently with this population include melatonin, Concerta, and risperidone. Lastly, the sensory integration theory uses exercises and activities to target some or all of the sensory system. These include vestibular, proprioceptive, auditory, tactile, and olfactory. On the right of the screen, you can see a great little visual that shows different theories and their proven effectiveness or lack thereof in the research. As you can see, ABA falls under the green zone, an effective, evidence-based, and recommended treatment. Sensory integration theory and the medical model fall under the yellow zone, which is proceed with caution as they lack the evidence to be considered best practice. Overall, our stance is that ABA has been shown in the research to be an effective, standalone treatment for those individuals with autism. Both the medical model and sensory integration theory do not have as strong of results in the research and, at best, could be used as an additional form of treatment by a qualified professional. Remembering, as outlined in our textbook, we cannot be providing SIT advice while in the role of a behavior analyst.
Thanks, Brittany. You were able to demonstrate how ABA is effective, evidence-based, and recommended versus the other treatments that fall short in some of those categories. While medical personnel and sensory integration therapists can positively affect individuals with ASD, they also are not evidence-based and show fewer results than ABA. Next, Ellen will discuss research in each field and help us further demonstrate why individuals choose each model and what they can offer to individuals with ASD.
The first treatment model I will discuss is applied behavior analysis. ABA is used as a treatment for a wide range of behaviors. Research that we reviewed showed promising support for ABA. ABA has been shown to be effective in the high-intensity in-home therapy setting and in lower-intensity school settings. One study conducted by Weiss and Del Molino showed that after 4 years of in-home ABA treatment, individuals made significant gains. Individuals were assessed using a pre-test and post-test of the Childhood Autism Rating Scale. The post-test showed that the severity of symptoms decreased for all participants in the study. Prior to intervention ratings were a mean of 45.7 and a standard deviation of 5.30. And after intervention ratings were a mean score of 26.6 and a standard deviation of 8.60. Another scientific article published by Ferran et al. Also demonstrated success for ABA in the treatment of ASD. After a year of low-intensity ABA treatment in a school setting, students made significant gains in many different areas. Some of these areas included academic and learning skills, language, self-help, play, and motor skills. Ferran et al. Also conducted 2 case studies on students at the school who exhibited challenging behavior. Through function-based ABA interventions, both students exhibited decreases in the targeted problem behaviors. According to Schreck and Miller, when it comes to ABA, it is the therapy best considered to be a gold standard treatment for ASD. Compared with the other models, it is the most empirically validated through scientific research. Unlike the other treatment models, ABA focuses on teaching new, socially significant skills that are individualized to the person, because ABA recognizes the diversity of behavior. ABA can be used to both increase and decrease behaviors. ABA uses least restrictive measures first and evaluates the effectiveness of the behavior change plan through data collection before moving to a more restrictive plan. Also, when it comes to long-term efficacy and generalizable outcomes, even though ABA usually takes more time to implement, it has still been found to be more cost-effective in the long run compared to the other models. The research that we reviewed for ABA makes it clear that it is the most ethical choice for treatment. The next option for treatment is the medical model. According to Hirosha et al., parent surveys show more than 50% of children with ASD are prescribed medication for mood and/or behavioral symptoms. The types of medications used include antipsychotics, attention deficit hyperactivity disorder medications, and antidepressants. Some of the behaviors that medications may be prescribed to help include aggression, self-injurious behavior, hyperactivity, anxiety, sleep problems, and other symptoms that are common in children with these disorders. Children and adolescents with autism spectrum disorder appear to be more susceptible to adverse side effects with medications. Therefore, initiation with low doses and titrating very slowly is recommended. AEDs, which are medications used to treat seizures, do not appear to have a large effect size to treat behavioral symptoms in ASD, but further research is needed. In children with autism spectrum disorders, risperidone and aripiprazole have established evidence for treatment of irritability and hyperactivity. Haloperidol has established evidence for the treatment of negative behavioral symptoms, and aripiprazole also has established evidence for treatment of stereotypy. While medications do have some support in reducing symptoms, they can also have side effects that can sometimes do more harm than good. Also, over time, effects of medication can wear off, causing a need to continuously up the dosages. Medicine, while sometimes helpful and also medically necessary, does not address behaviors at their function, and it also does not teach the individual anything new. Lastly, I will discuss sensory integration therapy. Sensory integration therapy is one of the most commonly used interventions for individuals with autism spectrum disorders. As stated before, it uses a mix of activities to engage the client's body. Common activities include tactile stimulation, pressure or compression, gross motor activities, and even includes arts and crafts. However, despite sensory integration's popularity, there are minimal positive results found. According to Schreck and Miller, a probe into PubMed and PsycInfo databases resulted in finding 0 articles to substantiate the claims of sensory integration. Curiously, Schreck and Miller suggest that some of the success stories of sensory integration can actually be explained from an ABA approach. They suggest that sensory integration techniques may be positively or negatively reinforcing the client. The activities may appear to be helping or calming the individual, but this can be explained because the actual activity being performed might be fun and therefore reinforcing. The individual may be also escaping other activities during this treatment. Also, during therapy, the individual may be receiving more attention than usual, which can affect their behavior and again be explained from an ABA approach. As a result of our research, we feel sensory integration does not have the scientific evidence necessary for us to give a reliable recommendation. It would appear that many of its positive claims actually have a behavioral explanation, and therefore ABA should rightfully be considered in its place.
Thanks, Ellen. To recap, ABA is empirically validated, which shows that it is ethically advanced and provided the most ethical and advanced treatment to ASD. Next, Brittany will discuss pros and cons of each model. A chart will help elaborate on the medical model versus ABA.
To illustrate both the pros and cons of all 3 of our research theories, we have created this chart to show both views. The medical model is quick and easy to implement, usually implemented by your GP or pediatrician. Immediate benefits can be seen. Sleep, for example. A parent can take their child in, pick up a prescription the same day, and notice the effects immediately. On the flip side, this model lacks the teaching component. No alternative replacement behavior. We may be getting rid of or decreasing problem behavior with the use of medication, but not adding the teaching component. Research also lacks in terms of the effectiveness of combining multiple medications and the reactions between them. The positive aspects of ABA include cost effectiveness, high treatment efficacy, and the targeting of socially significant behaviors. Unfortunately, due to past approaches used under this model, ABA still faces misunderstandings in the public's eye. Also, insurance may not approve the correct quantity of hours to see the best results. The sensory integration therapy also is easy to implement and includes socially acceptable activities. For example, a child's sensory diet may include a fidget item and a move and sit cushion for their classroom chair. Little effort is needed to put these into place and are just a subtle change in the classroom environment, so not to be a distraction to others. Unfortunately, there is still a lack of positive research and limited benefit shown with this theory. Remembering back to the chart shown earlier, this theory is still in the yellow zone, showing it is not yet considered an effective evidence-based theory. To further illustrate the research in terms of effective evidence-based theories, we looked at the extensive report put out by Ontaba in 2017. This comprehensive report would be a great tool for any future or current behavior analyst. This report aligns well with our presentation, outlining ABA as an effective and sensory integration as an emerging form of therapy.
Thanks, Brittany. The take home from that is that while the medical model is easy to implement, it can cause side effects and lacks a replacement behavior to replace the targeted behavior, which is essential. ABA was demonstrated by Brittany to be cost-effective, high treatment efficacy, in targeted significant behaviors. This is important because medication can work for some behaviors, such as sleeping, but it takes teaching and giving replacement behaviors for a significant behavior, such as aggression, to go away. Next, Madison will discuss the ethics involved in each model. She will go by the BACB, or Behavior Analyst Certification Board, and their Code of Ethics.
So some ethical considerations for the different models, according to the BACB Ethical Compliance Code, include but are not limited to the following codes: 4.09 and 2.09 for applied behavior analysis, 3.02 and 2.09 for the medical model, and 2.09 for sensory integration therapy, which I will go into further detail. Overall, applied behavior analysis is an ethical and evidence-based treatment model. Behavior analysts adhere to a strict ethical compliance code that is in place to ensure BCBAs make ethical decisions. BCBAs must choose the correct level of services to provide because ABA can take the form of intensive treatments. Especially since many non-professionals believe ABA is punishment-based, behavior analysts must use the least restrictive procedures first. According to Ethical Compliance Code 4.09, least restrictive procedures, behavior analysts review and appraise the restrictiveness of procedures and always recommend the least restrictive procedures likely to be effective. Next, the medical model can be used to look at clients with a disability as a cost or burden to society because it establishes the symptoms of autism spectrum disorders as something that needs to be treated with expensive medication instead of therapy, time, and advocacy. Furthermore, and as stated by Ellen previously, according to DePhillips 2016, children and adolescents with autism spectrum disorders appear to be more susceptible to adverse effects with medications. Therefore, initiation with low doses very slowly is recommended. The medications used to treat the symptoms of autism are effective in some cases, but often cause side effects that are worse than the symptoms the medications are treating. In regards to the BACB ethical code for behavior analysts, the medical model does not align with code 2.09 titled Treatment Efficacy, which states, clients have a right to effective treatment, i.e., based on the research literature and adapted to the individual client. And behavior analysts always have the obligation to advocate for and educate the client about scientifically supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to society. So behavior analysts should refer to their code of ethics and refer to a medical practitioner if they believe there is any reasonable possibility that a referred behavior is influenced by biological variables. Lastly, sensory integration therapy has not been found to be an evidence-based practice. According to a systematic review for sensory integration therapy in the treatment of autism spectrum disorders, sensory integration therapy had no consistently positive effects as a treatment for children with autism spectrum disorders. Practitioners and agencies serving children with autism spectrum disorders that endeavor or are mandated to use research-based or scientifically based interventions should not use sensory integration therapy out. Typically, sensory integration therapy in one or more of its various forms is delivered in one-to-one sessions and involves activities that many children find enjoyable, such as swinging, rocking, or massaging. Observation that a child likes an activity, however, is not by itself evidence that the activity is producing significant, lasting, and meaningful changes in the child's behavior other than momentary pleasure. So, although SIT is widely accepted by parents and reported to be beneficial in increasing adaptive functioning for their children with autism, sensory integration therapy would not align with the BACB Ethical Compliance Code 2.09, which is titled A Client's Right to Effective Treatment, because it has widely been found to be ineffective in the long-term treatment of autism.
Thanks, Madison. Applying the BACB ethical codes to each model helps demonstrate how ABA is the most ethically sound treatment for ASD. Next, Jocelyn will answer some questions about our models we have discussed.
Many questions have arisen when it comes to alternative models to address the quality of care for children with autism. However, here are 4 answered questions in the matter. Question number 1. Is there a time when ABA would not be the first choice of treatment? Limitations for the use of ABA lie on the obstacles that come along with the barriers that are culture-specific. When there is a treatment plan with the application of the ABA has passed or no longer essential as the client has grown, or the skills to be taught are useless or irrelevant. Parents have the tendency of seeking different treatments if ABA does not work quickly enough. ABA is based on trial, and if a client is very low functioning and a parent set out expectations for immediacy and results, the parent loses faith in this type of service treatment. Question number 2. How do family values and cultures play a role in choosing an appropriate treatment? All cultures are different, and some have expectations of immediacy and results and modifications in their children based on the skills and maladaptive behaviors targeting. If ABA increases behaviors through the application of the assessment process, then families might feel as an ABA treatment is not working or maybe making the issues so much more worse. In many other cultures, parent involvement is difficult to apply due to the cultural norms. Many families with more traditional backgrounds find that treatment is not as essential as the beliefs for the children's behaviors that are derived from internal matters other than external, where in many cases the extremities of the client might be what is provoking these issues. Therefore, ABA, as it is an intensive form of therapy, families may be against it and may choose a less intensive form of therapy, as in through occupational therapy. Question number 3. When referring to the lack of evidence, etc., what accompanies the sensory integration therapy? Why do you think that parents and professionals are drawn to this type of intervention compared to other ones? Do these children that do show these negative results are discharged based on the inability to progress in the non-ABA programs, for example, occupational therapy? Are parents unaware of the increase in behaviors because the data is not taken? And why is there a buy-in for therapy, even though many signs point to the ineffectiveness and lack of supporting data? Well, according to Kahn, Miller, and Tico Diamond, parents have shared testimonials that sensory integrated mode of treatment approaches have improved the quality of life for their families. They now understand that they have seen improvements in their children's behaviors. They would learn modes that would teach parents on how to regulate their children's emotions, teach children about self-confidence, and have their children develop behaviors and skills needed to fit in or belong to the rest of the community. Discharging these special needs children from the services that they will need is a is a demonstration of negligence due to the fact that these children will one day become adults without the skills to be independent individuals. Parents lack the knowledge of why these children cannot behave like normal developing children. Nevertheless, know if lack of data is the reason why maladaptive behaviors may increase. It is our responsibility as professionals to teach parents all these skills. It is important to gather data to analyze trends and behaviors to eliminate or modify as needed. Families might trust this type of therapies due to the lack of knowledge in other methods of treatment, or because they trust therapy through the sensory integration as the best due to its applications rather than through ABA. And question number 4. In today's society, many people think that cures can be found in medicine for any type of behavioral issue. Many doctors are prescribing medications without first trying other therapies. If a parent of a child with no medical cause for their behavior, for example, those with UTIs, migraines, or etc., come to you and ask if their child should be put on medication as a BCBA, how would you handle this? Cite the ethical codes in my explanation. So in section 1.02, under boundaries and competence, it states, A, all behavior analysts provide services, teach and conduct research only within the boundaries of their competence, defined as being commensurated with their education, training, and supervised experience. And B, behavior analysts provide services, teach and conduct research in new areas, an example, populations, techniques, behaviors. Only after first undertaking appropriate study, training, supervision, and or consulting from persons who are competent in those areas. And in section 2.03, under consultation, it states, behavior analysts arrange inappropriate consultations and referrals based principally on the best interests of their clients, with appropriate consent and subject to other relevant considerations, including applicable law and contractual obligations. And B, when indicated and professionally appropriate, behavior analysts cooperate with professionals in a manner that is consistent with the philosophical assumptions and principles of behavior analysis, in order to effectively and appropriately serve their clients.
Thanks, Jossie. In conclusion, we believe ABA is the standard of treatment for individuals with autism spectrum disorders. We believe this because ABA is an evidence-based practice, adheres to the ethical codes we stand by, and shows a positive outcome for individuals who receive ABA services. Thanks for joining in on our presentation.